What's up, Ninja Nerds? In this video, we're going to be talking about acute pancreatitis, so buckle up. If you guys want to follow along, though, with some awesome notes, some illustrations, please do so down in the description box below. There'll be a link to our website. Go check that out. Also, if you like these videos, you benefit from it, it truly helps, and you have fun, please support us by hitting that like button, commenting down in the comment section, and please subscribe. Let's get into it. All right, Ninja Nerds, so let's talk about pancreatitis. First off, acute pancreatitis is an inflammation of the pancreas. Now, we know that the pancreas is a very special type of heterocrine gland, right? So it's an endocrine gland and an exocrine gland. We're going to be kind of focusing more on the exocrine portion, which is the secretory portion that makes different types of digestive juices, right? So when we take a look at the pancreas in general, right, you know that you have this little ductal system here. So you have all these pancreatic ducts, and the whole point of the pancreatic ducts is that from these pancreatic ducts, it connects, particularly the main pancreatic duct, connects to our GI tract. And that's where we dump a bunch of different things into the actual duodenum. So this kind of tube here would be representing the duodenum. And then this here is the pancreas. Now, the pancreas makes a bunch of different types of things, digestive juices, which consist of pancreatic enzymes and a bicarbonate-rich fluid. But in order for us to understand those two different things, we have to really zoom in because there's two components of the pancreas. So the pancreas is made up of a bunch of different portions, right? So the biggest part is that we have this ductal system, and there's a bunch of different ducts, right? So you have the main pancreatic ducts, you have all these different types of small little ducts as well. Then you have this portion here, which is these like little sac-like structures here that we're going to zoom in on. And these are called the acinar cells. So let's kind of take a look at these kind of in a zoomed in view. So again, what I want you to remember is pancreatitis, inflammation of the pancreas. What's the big function of the pancreas? It secretes different types of pancreatic juices, digestive enzymes, bicarbonate-rich fluid into the GI tract, particularly the duodenum. Now, if we zoom in on kind of parts of that pancreatic structure, we have here our ductal system. So this is our duct. And then we have these tiny little accessory ducts, right? These tiny little ducts that are coming off here and branching into these things called acini. Now, what I want you to remember is we're going to represent these as purple. These little cells here that are lining these tiny little ducts. This is called our ductal epithelium. Now, what's the purpose of the ductal epithelium? It's supposed to make a bicarbonate-rich type of pancreatic fluid. So that's the job of these little ductal cells. The job of the ductal cells is to be able to secrete kind of a nice, thin, bicarbonate-rich pancreatic fluid. Okay? That's the job of it. Now, these cells here, which are called your acinar cells, which are the ones in orange, right? So what are these cells here called? These are called your acinar cells. Let's zoom in on them and see what particularly they do. So we know that the little ductal epithelial cells make pancreatic secretions and fluid rich in bicarbonate. The acinar cells, these bad boys, the acinar cells are the secretory cells. These are the ones that make all of those digestive enzymes. Okay, and there's a bunch of different types of digestive enzymes that they make, and we'll talk about some of these. But what I want you to remember is, here we have these acinar cells. We're zooming in on one of these little acini, okay? These acinar cells have their nucleus, right, which contains their DNA, right? The DNA has to get transcribed. When it gets transcribed, it makes something called mRNA. mRNA will then go to our rough endoplasmic reticulum, which contains ribosomes. It'll get translated into proteins. Those proteins will then get synthesized into vesicles. Those vesicles will then get taken to the Golgi. The Golgi will then go ahead and form those, modify them a little bit, and package them into nice little vesicles. So now we're going to have here a vesicle, which is going to be containing a bunch of different types of proteins and enzymes and things of that nature. Okay, so let's say that we take a look and kind of zoom in on these like vesicles that contain these very interesting types of digestive enzymes. So here we're zooming in on this granule here. So this is a granule located inside of the acinar cell. In this granule, we have these things in here called zymogens. So zymogens are basically the inactive form of the enzyme. So I just want you to remember they're the inactive enzyme. So it's just the enzyme in its inactive form. Now, there's different types of these enzymes. Let's imagine here these blue ones here. These blue ones here, these are called, let's say, lipases. So you have different types of enzymes. You may have what's called lipases. You may have these ones here in maroon. Let's say these maroon ones here. These are called amylases. So what do lipases do? They break down lipids. They break down triglycerides. Amylases break down sugar. What else could we have in here? Now the red ones is the one that I want you to remember. These are your proteases, and these are the ones that are going to be breaking down tons of proteins. And then you have one thing in there, because here's the thing. These zymogens, they're the inactive enzyme. We don't want them to be activated unless there's a particular scenario where we need them, which is we need them in the duodenum, and then they get activated there to be able to chop up the different proteins that we consume in our diet, to chop up the lipids in our diet, to chop up the carbohydrates in our diet. But when they're in our cells being stored, we do not want them to be activated. So we have a very, very special enzyme that sits within these granules to keep the proteases inactivated. Very specifically, the proteases. What do you think we call this black enzyme here? This is called the protease inhibitor. Real original, right? It's a simple thing. So we have protease inhibitors which are present in these granules to keep them in the inactive state. We don't want them to be activated when they're not in the duodenum, okay? So here's what I want you guys to remember. How does pancreatitis develop? Inflammation of the pancreas, but very, very specifically, damage of the pancreas that maybe alters the digestive enzyme secretion into the duodenum. You know how this actually happens? It happens by two ways. One way is we have some type of negative effect here. There's some type of obstruction within the ducts, okay? That's one particular thing. If you have an obstruction, so let's imagine here, let's say that you have like some type of obstruction, whatever the reason is, we'll go over the different causes. But let's say that here that you have an obstruction in this duct, you have an obstruction here at this part of the duct, you have an obstruction at this part of the duct. What's that going to do? You're going to have all these secretions that are going to build up behind that blockage. And so that's going to cause the pressure to start rising. And if the pressure starts rising in these ductal cells and in the acini, guess what that pressure does? It alters the normal movement of enzymes. If you kind of alter this basic process where you want to kind of excrete out these different enzymes, okay? You know what happens? You know what you have inside of your cells? You have these things called lysosomes. And whenever you have this back pressure due to some type of obstruction and the pressure builds up behind that obstruction, this alters the normal excretion process of the zymogens. And then the lysosomes will start fusing with these actual granules containing the zymogens. You know what lysosomes can do? Lysosomes can activate specific types of proteases. And you know what that leads to? Oh no. Then I'm able to release out these active proteases. And these active proteases will start causing destructive damage to the pancreas, autodigestion of the pancreas. So that's one way. One way that we can lead to pancreatitis is you develop an obstruction within the ducts causing a back pressure, altering the normal movement of enzymes, which should go mRNA to ribosomes, to packaging into vesicles, to Golgi, to granules, which should be excreted and then activated in the duodenum. But because of the obstruction, the back pressure alters this normal movement. Instead, this obstruction of the ducts leads to lysosomes inadvertently fusing with the granules, activating those proteases when they should not be activated in the pancreatic acinar cells in the ducts, and it starts auto-digesting the pancreas. That's one way. You know what the second way is? The second way that we can cause this is you cause damage the acinar cells directly. If I damage the acinar cells directly, I damage these, this can also stimulate this process. It can also lead to the release of these zymogens, the release of the lysosomes. They can then become activated within the pancreatic ducts or smaller ducts. Boom. You lead to activation of pancreatic proteases. They start causing autodigestion of the pancreas. So now my question to you is, what are the things, the particular types of causes that lead to obstruction within the ducts or lead to direct destruction of the acinar cells that leads to autodigestion of the pancreas? I'm so glad you asked. So the first one that I want you guys to remember is gallstones. This is by far the most common cause. So gallstones, how does this do it? Well, you know, you have your gallbladder here, And then the gallbladder has what's called the cystic duct. Then the cystic duct will fuse with the common hepatic duct to make this thing called the common bile duct. Well, you know the common bile duct will come down and fuse with this orange structure here. What's this main duct of the pancreas called? This is called the main pancreatic duct. When they fuse, they make this structure called the hepatopancreatic ampulla. Now, this portion here is where you spit the digestive juices, the pancreatic enzymes, the bicarbonate-rich fluid, and bile all into the duodenum. This is all at that portion right there. What if someone gets a stone? They have a gallstone here. That gallstone pops out, and it gets stuck right here at that hepatopancreatic ampulla. Now, if it gets stuck here, can you secrete all these digestive enzymes out? No. What happens? You start developing an obstruction and a back pressure. What does that back pressure do? It alters the normal movement of the zymogens to be secreted. They inadvertently combine with the lysosomes. They lead to the fusion and then lead to the direct activation of those enzymes. And they start causing destruction of the pancreatic tissue, autodigestion. So this is one of the causes that I want you guys to remember. The most common cause is going to be gallstones. So the most common. Okay? And specifically gallstones that form right at that hepatopancreatic ampulla. Okay, what's the second most common cause? The second most common cause is ethanol, so alcohol abuse, right? Usually you see this particularly in patients with chronic pancreatitis. So they have chronic pancreatitis because they're constantly drinking alcohol, and then they develop an acute exacerbation of their chronic pancreatitis, okay? So how does ethanol do it? Ethanol is a son of a gun. It does it by a bunch of different ways. One, it's weird, is imagine here's kind of a glass, right? A glass of wine. This actually can directly stimulate your acinar cells. It's really weird. They can take and work directly on the acinar cells. And when they work directly on the acinar cells, they cause these zymogens to be released. So they increase the release of these zymogens. But whenever they do that, because you're pushing so much of these zymogens out into the actual ductal system, some of these can get undesirably activated and start causing pancreatic autodigestion. You know what else it can do? It's an interesting thing. It can also tell the epithelial cells. Remember those ductal epithelial cells that we have right here? These ones right here? It tells these ductal epithelial cells to make a very thick type of bicarbonate-rich secretion. So it really makes it a super, super thick kind of mucousy type of secretions here. And as you start getting a lot of these thick and mucousy types of secretions because of the alcohol, what does that do? That plugs up the ducts, it obstructs them, causes back pressure, alters the normal movement of the zymogens, leading to them combining with the lysosomes, and then inadvertently leading to them becoming activated, pancreatic autodigestion. Okay, so that's another way as we can lead to increase thick ductal secretions. The next way that it actually can work is it can activate these things called neutrophils. So one of the things that we see is that the alcohol can actually activate and stimulate neutrophils. You know what neutrophils can do? If you have lots of alcohol and you stimulate the neutrophils, particularly to come to the area of the pancreas, it increases the production of reactive oxygen species. It increases the production of proteases. And what do these do? They lead to direct destruction of the acinar cells. If you destroy the acinar cells, you cause them to release tons of zymogens. If they release out these zymogens, and it leads to the proteases getting activated, what are the proteases going to do? They're going to cause autodigestion of the pancreas, lead to inflammation. Boom, roasted. So we got gallstones as the most common. Ethanol is the second most common. Let's come down to the third thing. The third one that I want you guys to remember is trauma. But again, it's a simple concept. Any kind of trauma, really, it has to be more specific, like a penetrating trauma, because that's going to cause direct damage to the acinar cells. So we want to really think about this as a penetrating trauma. So imagine someone running around with a meat cleaver or like some type of like sickle, and they're trying to cut you up, right? So some type of penetrating trauma is going to cause direct injury to the acinar cells. If you directly injure the acinar cells, they increase their zymogen release. And if you increase the release of the zymogens and you stimulate those proteases, they're going to start causing destruction of the pancreas, autodigestion. Okay, The next one that I want you guys to think about here, this one's actually it's not super common, but it definitely is something to be keeping on your differential, is hypertriglyceridemia. Triglyceridemia. This basically elevated triglycerides within the blood. But whenever you have hypertriglyceridemia, you know triglycerides, they're actually particularly absorbed across the GI tract. And when they're absorbed across the GI tract, they actually get packaged in our enterocytes. And when they get packaged into our enterocytes, they get packaged into these little thingies, these tiny little like lipoproteins, which are called chylomicrons. You guys know those structures? They're called chylomicrons. We'll abbreviate it CH. So you absorb the triglycerides across the GI tract. And if somebody has some type of genetic disorder, or they're just having a large consumption of triglycerides, they're going to get lots of chylomicrons. So anything that really increases your triglycerides, whether it's a genetic cause, whether it's because you have a high consumption, whatever it is, lots of these chylomicrons get actually taken up into eventually they get into the lymphatic circulation, then they get into our blood circulation. Once they get into the blood, these tiny little guys, they're tiny little ones, they can get stuck in small capillaries that supply the pancreas. So if these chylomicrons get stuck in these capillaries, what happens to the oxygen supply to the pancreatic tissue? There's a decrease. So now there's a decrease in the oxygen supply. What happens if you have less oxygen that you're supplying to tissues? They can start to become ischemic. And what happens if that ischemia isn't actually corrected? It can lead to necrosis or death of the pancreatic tissue. And that can therefore lead to pancreatitis. So we have so far gallstones, we have ethanol, we have penetrating trauma, and hypertriglyceridemia. Let's come up and talk about more potential causes. All right, what's another common cause? Another one that you want to be thinking about is if someone is taking any kind of corticosteroid. Okay, so this is technically a drug-related one, but it's a very specific one, and it's going to help us out with our mnemonics. So steroids can also do this. And steroids are interesting because, again, they work on that ductal epithelial cells. And you know what they do to the ductal epithelial cells? They tell those ductal epithelial cells to increase their secretions to make them a little bit thicker. And so as a result, the secretions by the ductal epithelial cells become thicker. If you have an increased thick secretions, that's going to cause an obstruction within the ductal system. And that obstruction is going to lead to eventually the higher pressures altering the normal cascade movement of the zymogens being secreted and then being activated in the GI tract. Instead, they become activated in the cells and then released. This can lead to destruction of the pancreas. And that then can lead to pancreatitis. Okay, what else? The next one, especially in children, you want to think about this, is the mumps virus. So the mumps virus can also do it two ways. One is that this virus has the ability to directly act on the ductal epithelial cells and destroy these epithelial cells, but also they have an ability to act directly on the acinar cells. And if they act on the acinar cells, they cause the release of the zymogens. If the zymogens are released, they have the ability to increase their activation by combining with different types of hydrolytic enzymes, particularly from the lysosomes, and increasing the activity of the proteases, and those proteases will start causing destruction of the pancreatic tissue. What else? So not only is it that, let's come down and talk about another one. Another particular one that you want to be thinking about is autoimmune. You know, in autoimmune diseases, very, very specific types, like for example, you know, whenever you produce antibodies against your own tissues, unfortunately, in certain conditions, you know, for example, like maybe you produce these things called G4 antibodies, that could be one, or you're producing other different types of antibodies related to SLE, related to rheumatoid arthritis. You know, these different types of antibodies may go and actually directly destroy the epithelial cells that are actually secreting that bicarbonate-rich fluid, and they may go and actually destroy the acinar cells, leading to the inadvertent release of the zymogens and their undesirable activation to form activated proteases. And now that these activated proteases are formed, they can start causing destruction of the pancreatic tissue. Boom. So we kind of got a kind of similar kind of flow here, right? So mumps, autoimmune, guess what? This one here, it's probably the most random one. It's the most interesting, but it's probably the most rare, and it's scorpion bites. So scorpion, particularly the toxin that's released by the scorpion. So whenever the scorpion stings, it releases a toxin. And that toxin that it actually releases causes destruction of the epithelial cells of the ducts, which again alters the bicarbonate-rich fluid secretion, but it also causes direct destruction of the acinar cells, releasing out those zymogens. Those zymogens become undesirably activated, and when they become activated and form those proteases, these proteases then start causing destruction of the pancreatic tissue. Oh my gosh, it's like a never-ending cycle here, right? The last particular cause that I want you guys to think about here, well actually getting close to the end here, is drugs. Now drugs may do this by a bunch of different ways, particularly kind of inside of the cell where we don't have a complete understanding of how exactly these drugs do this, but we know that there's very specific drugs that seem to track along with this disease. Some of those that I want you guys to remember tend to be your sulfa drugs. So any kind of sulfa drug, whether that be like Bactrim, sulfasalazine, which is kind of used as a, particularly in like IBD, even like furosemide, like any of those loop diuretics, those potentially can cause pancreatitis. Another thing that you want to remember is any kind of like HIV medication, particularly like your NRTIs or your protease inhibitors. Those can do it. And another one is certain types of diabetic medications, particularly those of like the GLP-1 diabetes meds. Okay, diabetes mellitus medications. There's a bunch of different medications that can cause this, but I want you guys to be thinking about like any kind of sulfa drug, HIV medications, your GLP-1 medications. These potentially can cause pancreatitis. Okay, over here we have another potential cause. This one is a very interesting one. It's another one that you definitely want to remember. It's called an ERCP. Okay, so an endoscopic retrograde cholangiopancreatography. So ERCP, it's basically a procedure that we do in someone that we think has a gallstone type of cause for pancreatitis. Or they have some type of thing where we need to go up and remove some type of stone. So you basically take this camera, you go around here where that hepatopancreatic ampulla is, you make a little cut of the hepatopancreatic sphincter, this little muscle here. You go through the duct, and then you go up through the common bile duct. And if someone has maybe like a gallstone right here, it can utilize that to diagnose the particular stone and remove the stone. So it's kind of a therapeutic process. But if in the process maybe that causes damage to the pancreatic tissue, that can then lead to the destruction of the acinar cells, causing them to release the zymogens, increase the protease activity, and then cause destruction of the pancreatic tissue. The last particular cause that I want you guys to remember here is called hypercalcemia. So hypercalcemia. So hypercalcemia is a very interesting one. It's also a very rare cause. But what happens is, let's say that somebody has hypercalcemia. When they have hypercalcemia, a lot of that calcium is distributed through the blood, taken to different areas, certain organs like the pancreatic tissue. Whenever calcium is in high concentration, calcium can actually directly stimulate these enzymes. It can act as a kind of like a precursor to these enzymes and stimulate the particular proteases. So normally your proteases should be held inactive, but in the presence of calcium, calcium can actually stimulate those proteases. So as a result, you may have an increase inadvertent activation of proteases, and those proteases can therefore cause destruction of the pancreas. Now, before we move on here, what I want you guys to think about is how really the whole problem is that the pancreas is supposed to be kind of doing what? Here's your pancreas, all right? So here's our pancreas. And let's say here's going to be the GI tract. All right, so here is our GI tract. Normally what happens is the pancreas is supposed to secrete these digestive enzymes into what? Into the duodenum. And then in the duodenum, there's supposed to be very special enzymes. Let's just put this enzyme here in like pink here. This is a very special type of enzyme. We'll call it an enteropeptidase. Okay? So this enzyme is called an enteropeptidase. And what this enzyme is supposed to do is those pancreatic enzymes, they're supposed to be inactive when they're present in the pancreas. Once they're secreted, they're still inactive. But once they interact with that enteropeptidase, they go from inactive to active. So they're not supposed to be active until they're present in the duodenum. And all of the processes that we just mentioned above, whether it be due to an obstruction of the ducts that's altering the normal movement, like cellular processes and cellular trafficking, which leads to the inadvertent activation by combining with lysosomes, or you're destroying the acinar cells, causing the pancreatic enzymes to be released into the ductal system, and then they become activated. Either way, they're becoming activated in the pancreas rather than in the duodenum, and that's the whole issue. Now my question to you is, how do I remember all of these causes? Because there's so many of them. Don't worry, you can remember the mnemonic, I get smashed. All right, so how do we remember all of the causes? Because there's so many of them. You guys are like, oh my gosh, I can't tolerate all these things. Don't worry, I got you. So you can remember all of these causes by the mnemonic, I get smashed. So I for idiopathic, meaning we don't have any idea how the heck this happened. G for gallstones, which is the most common one, so don't forget this one, please. Ethanol, which is the second most common one, and trauma, penetrating trauma. S for steroids, M for the mumps virus, A for autoimmune, which like think about SLE, think about particularly rheumatoid arthritis, scorpion bites, which is probably one of the more rare ones, but it's the cool one, and then H, it's a double, hypertriglyceridemia and hypercalcemia. Then we also had the ERCP and the drugs, the sulfa drugs, the HIV medications, some of the anti-diabetic medications of the GLP-1 category. So these are the particular causes that if you want a quick remembering of all of these causes, and we can just move on to pathophys, utilize this mnemonic. Now let's talk about the pathophysiology. All right, so let's talk a little bit about the pathophysiology of acute pancreatitis, right? So we have an understanding of the particular causes, I get smashed, right? Or the particular things that we just reviewed. Now, once these particular causes lead to the damage of the pancreas, the inflammation of the pancreas, it'll lead to the very obvious clinical features and complications of pancreatitis. What are those clinical features? So think about it. Where is the pancreas located? Location-wise, it's located within the epigastric quadrant. Right, so the epigastrium area, right here. Okay? Now, within that area, if there's lots and lots of inflammation of the pancreas, it should produce a referred pain localized to that area. So what do we call that type of pain? We call this a epigastric abdominal pain. Okay? Abdominal pain. Now, there's a couple things that we definitely need to talk about with respect to this pain that they may ping you on for the exam. One of the things is that there's other things that are in that area that can also present with that kind of epigastric abdominal pain, like a peptic ulcer disease. So how do I differentiate that this isn't peptic ulcer related and it's actually pancreatitis related? Well, one of the big things is that the pain is constant, and where peptic ulcer disease is kind of intermittent. It depends upon what type of times we're eating food, right? So it's more dependent upon meal times. So that's one big thing. It's a constant pain. The other thing is it radiates. Where does it radiate to? Well, it radiates into the back. Peptic ulcer disease does that as well, but it's different in the sense that it's constant, whereas peptic ulcer disease is in different times that we're eating. So it radiates to the back. That's another big thing. Here's the next thing that I need you guys to remember. The other important type of piece of information is that there's certain positions that make it worse and certain positions that make it better. When you're laying on your back, you tend to stretch that area and cause a lot more pain. So when you're laying supine, laying down on your back, it's actually much worse. So the pain is much, much more worse. So that's one of the big things that you can remember, is that laying supine, it causes the pain to become worse. Whereas if you're leaning forward, sometimes they'll kind of lean forward. This will make the pain much, much better, and it just feels a little bit more comfortable, less stretch on that area of the pancreas. Okay? So that's the big things that I really want you guys to remember, is very specifically epigastric abdominal pain. How do we OPQRST it? We know that it's constant. We know it radiates to the back. It's better whenever we're leaning forward, and it's worse whenever we're actually laying down flat or supine. Okay, the other thing that I want you guys to remember is respect that it has on our GI tract. So imagine you have a lot of inflammation of the pancreas. Nearby, what structures does it run nearby? Well, here we're gonna have the duodenum, and then right above it, we're gonna have the stomach. Imagine causing so much inflammation that it causes the irritation and inflammation of the nearby structures. Enough so that if you have enough inflammation, what could this potentially do to the lumen of the duodenum? What could it potentially do to the lumen of the gastric outlet tract? What could this do? It could narrow it. And all of that inflammation will alter the normal movement of food. Normally food wants to move from our stomach and then into the duodenum, and then move from the duodenum into the jejunum, so on and so forth. But if you have so much inflammation because of the pancreas and the nearby inflammatory collections that it causes, it may cause inflammation of nearby structures, or so much inflammation that it's compressing on nearby structures. If it's compressing near the duodenum, are you going to be able to get food past that? No. If you're compressing it near the gastric outlet, are you going to be able to get food past that? No. So as a result, this may lead to abdominal distension, because these areas are just going to balloon up like the Michelin Man. And then if it gets so bad to where it distends it so much and you can't have food moving down, guess where it's going to go? It's going to come up. And this may lead to the respective nausea and vomiting as well. So these are big things to remember. You know what else it can do? Because of all this inflammation nearby, sometimes it can even hit nearby like small intestine areas. It can affect their motility. And if you have so much inflammation that it actually decreases the motility of the small intestine, this can present with an ileus. So it can have a decreased contraction of the smooth muscle. So it can present somewhat like a bowel obstruction, but it's not a mechanical bowel obstruction, it's like a physiological one. And so sometimes if you're actually auscultating their belly and they're having less motility, what would you hear less of? Less bowel sounds. So sometimes they may have decreased bowel sounds as well. So that's a big thing to remember. All right, we got a good chunk of this down now. Epigastric abdominal pain, constant, radiates to the back, worse when laying supine, better when leaning forward. If there's a lot of inflammation, compressive symptoms, abdominal distension, nausea, vomiting, functional type of or physiological ileus with decreased bowel sounds. Boom, yada yada. What else can happen? Okay, the next thing that you guys have to remember here is one more. This is an interesting one. What if I have a gallstone? This is just kind of because gallstones seem to be the most common. What if I have a gallstone somewhere along that hepatopancreatic ampulla, right? A stone's getting stuck. Can bile get pushed down this normal gallbladder, cystic duct, common bile duct into the duodenum? No. And so as a result, bile will start backing up. And when bile backs up and gets into our circulation, what's the primary pigment component of the bile? Bilirubin, right? So you get what's called bilirubin. And if bilirubin gets into the bloodstream, a lot of it, what can this produce when it gets deposited into our skin tissues? Jaundice. So another potential symptom that you guys want to be looking for, especially as cueing you in on maybe the etiology or the cause of this person's pancreatitis, is also jaundice. Okay, beautiful. Now let's talk about some of the complications. Pancreatitis is just this massive inflammatory reaction, man. So whenever there's this significant inflammation of the pancreas because of the causes that we talked about, so there's already been pancreatic destruction and damage. When that happens, it pulls in, you know, whenever the pancreas tissue is damaged, it releases different types of chemokines and kind of inflammatory mediators like prostaglandins and leukotrienes and bradykinin, all these different types of molecules that try to pull in white blood cells to the inflamed area. Because we want white blood cells to come in and clean up all of that debris. When it comes to that area, it brings with it neutrophils and it brings with it macrophages. And what happens is these guys, unfortunately, some of the more neutrophils that come to the area, they try to release reactive oxygen species and proteases. And unfortunately, in an attempt to try to help like whatever's going on, it may unfortunately lead to an increased destruction and propagate this process even more. But what this may do is it may stimulate the macrophages, very specifically, and cause these macrophages to lead to a ton of cytokine release. You know, very specifically interleukin 1, interleukin 6, TNF alpha. These very, very specific molecules get released. And you know what these guys love to do? They love to act on our vessels. So you release tons of these molecules because of the massive pancreatic inflammation. These love to act on our vasculature. And you know what they do to the vasculature? They cause the blood vessels to undergo a vasodilatory response. So that's the first thing that happens, is they undergo a vasodilation response. That's the first thing. The second thing is they cause them to become very leaky and very permeable. So they cause the endothelial cells to kind of contract near one another. And as a result, the endothelial cells start leading to a lot of leakiness. So as a result, we'll put this kind of here in brown. Now, any of the fluid that's running through here can start leaking out of the vasculature and into the interstitial spaces. What's the end result of all of this crap? The end result of causing vasodilation, increased capillary permeability, is a bunch of different things. One is if you cause vasodilation, that's going to lead to a decrease in the systemic vascular resistance, and that's going to lower your blood pressure, so it can cause hypotension, right? The other thing is that if you have an increase in the capillary permeability, that's going to cause a lot of edema, like interstitial edema. So edema is going to fill up in different areas of the body, so it's going to cause interstitial edema. But also, you're going to have a decreased effective arterial blood volume, meaning that out of all the actual volume in your blood, because you know blood is made up of plasma, which is primarily like water, fluid, and it also has your formed elements, your red blood cells, your platelets, your white blood cells, all that stuff. If you have an increased capillary permeability, you're just leaking all of that fluid and you have less fluid within the vessel. So these are things that I want you guys to think about that may happen as a response to this. Now, here's the next thing. So we know that we get this vasodilation, we get this increased capillary permeability. Here's what I want you to remember. This vasodilation is widespread. And if you have this vasodilation, it leads to a drop in the systemic vascular resistance, a drop in the blood pressure, right? What's going to happen? What's the heart going to do in response to a low systemic vascular resistance and a low blood pressure? Well, it's going to activate those baroreceptors. So what it does is it stimulates the baroreceptors. You know those receptors that are present like in the carotids and in the aorta? It's going to activate those. And it's going to increase the activity of your sympathetic nervous system. And you know what your sympathetic nervous system is going to do? It's going to act on those SA node, it's going to act on the AV node, and it's going to try to increase the conduction through the heart. And you know what that's going to do? That's going to try to increase your heart rate. Because you know if you try to increase your heart rate, it's supposed to increase your cardiac output and increase your blood pressure. So that's what's going to happen, is that as a result, they develop a increase in heart rate. The other thing is if you have less blood volume, so if you have less blood volume, like effective arterial blood volume, because you're leaking it all over the dang place, less blood is getting taken to the right heart. Less blood is going from the right heart to the left heart. And less blood is getting pumped out of the left heart and into the systemic circulation. And that is also dropping your cardiac output and dropping your blood pressure. So you get kind of a double whammy effect here. You get the vasodilation that causes your actual blood vessels to become wider, lower the resistance and lower the pressure. That creates a reflexive tachycardia. But if you're leaking all of your fluid into the interstitial spaces and less of it is actually in your vessels, that means the venous return is less. And you have less blood that's actually being pumped through your vasculature. That also can lead to hypotension. So we see hypotension and tachycardia as a potential complication. Oh, man, what else could we see? Another thing that we can see from this is these cytokines, they're sons of guns, man. These cytokines, these interleukin-1, the interleukin-6, the TNF-alpha, all of them can have multiple effects on other organs, like peripheral organs. And one of the things that we start to see out of this is that it can act on our coagulation system. You know we have different types of coagulation enzymes. We have what's called procoagulants. We'll put pro-coag, and then we'll put anti-coag proteins. These cytokines love to ramp up the activity of the procoagulant enzymes and decrease the activity of the anticoagulant enzymes. And you know what that leads to? If you ramp up the activity of these, imagine you're going to have these proteins running down here. Let's say that these start clotting up a bunch of different areas here along this vessel. So now I'm going to be using up a bunch of these clotting proteins to lead to clots. But then I use up so many of these clotting proteins that I actually consume so much of those clotting proteins. So I consume the clotting proteins. that guess what? Next time I get like a little nick in the vessel, I'm not going to have the clotting proteins present because I've consumed all of them to make a bunch of clots. So I got clots all over the dang place because I've consumed these proteins. And I consume so many of them that now when I need them, they're not there. And as a result, blood can start leaking out. And what's the end result of this? This can also lead to bleeding. Seems paradoxical, right? This is a nasty disease whenever you develop widespread blood clots and then also bleeding. What is this condition called? This is a nasty disease. This is called disseminated intravascular coagulation. So that's another thing that you want to be thinking about. You know what else this interleukin 1, interleukin 6, TNF alpha also does? It's a son of a gun, right? It also can act on our hypothalamus. Stimulates our hypothalamus and tells our hypothalamus to start jacking up our body temperature because there's inflammation somewhere in our body. And if we jack up the temperature, it's a thought that like, oh, this inflammation is infection related. If we increase the body temperature, bacteria can't survive in a way. And so what happens is this stimulates your hypothalamus and your hypothalamus increases your internal body temp. And this can lead to a fever, which is another common clinical manifestation of someone with pancreatitis. All right, so what do we got so far? We know that we have hypotension, tachycardia. We got potential for DIC. We also know that we can have fever. And what else is another potential complication? These high amounts of these cytokine storms can also act on our bone marrow. It can activate the bone marrow. You know why? It can tell the bone marrow, hey man, there's a lot of inflammation going on. Get a lot of neutrophils to this area because something's funky is going on. So it activates our red bone marrow and tells them to start pumping out white blood cells. So pumping out white blood cells. And what is this called when you increase the amount of white blood cells? Leukocytosis. So there may be a leukocytosis. So we have fever, leukocytosis, hypotension, tachycardia, potential for DIC. What else? These cytokines can also act on our liver. And it can tell the liver, hey man, lots of inflammation going on. You need to go ahead and alert other parts of our body to let them know. And so the liver releases a bunch of different types of protein called acute phase. What are these called? Acute phase reactant proteins. And there's some very, very specific ones that I want you guys to remember. The big one here is called CRP. And there's another thing where it actually can affect what's called our erythrocyte sedimentation rate. Not as specific, but it's similar to this, ESR. So this could be measures of acute phase reactant proteins or inflammation, generalized inflammation in the body. And so CRP, ESR will be elevated. There's one more protein, I'm not going to get too crazy about it, but sometimes there's another protein that can be way more specific for kind of infection related things, and we'll talk about it a little bit later, but it's called procalcitonin. And it's a little bit more sensitive than CRP is, but we'll talk about that later with the diagnostics. Okay, so what do we got so far? We got the complications in the cardiovascular system, we got DIC, we got fever, we got leukocytosis, increase in CRP and ESR. Let's come over here. All right, so the other really scary thing from here that we got to talk about is, remember we said that very specifically there was a vasodilatory effect and there was an increased capillary permeability. And this is widespread, okay? It's not just happening near the area of the pancreas. This stuff is going all over the actual circulation. When it gets to the lungs and it increases the capillary permeability in the lungs, this can become a very, very nasty, devastating effect. Like super scary. You can increase the capillary permeability of those pulmonary vessels, and now as they're more leaky, you can have fluid leaking out of the blood vessels into the interstitial spaces. And then worst case scenarios, not only does it leak into the interstitial spaces, but it also starts leaking into the lung parenchyma, like near the alveoli. What is this called? This is pulmonary edema. But it's so diffuse because you have this massive increased capillary permeability that when this happens, this occurs diffusely throughout multiple alveoli. Worst case scenario, this can lead to what's called ARDS. And this is the #1 cause of mortality in patients with pancreatitis. So you can't forget that. Another super rare complication, I don't want to get too crazy, but sometimes if you get lots and lots of inflammation of the pancreas, sometimes the pancreas, if it gets really, really inflamed and sometimes necrotic, it can actually fistulize through the diaphragm. You know the diaphragm is a structure here that's supposed to kind of run underneath here. Sometimes in worst case scenarios, this pancreatic inflammation can actually destroy through the diaphragm and form a fistula between the pancreas and the pleural cavity. And that can cause fluid, all that inflammatory molecules, to leak into the area of the pleural cavity. What's that called when you get fluid, tons and tons of fluid within the pleural cavity? A pleural effusion. So another potential complication is what's called a pleural effusion. Okay, so we know that's particularly seen with a pancreatic fistula, all right? All right, what else is happening here? Because of that increased capillary permeability, this is going to affect lots of leakiness and fluid collections within the abdomen, which is where the actual pancreas is kind of located. It's within that retroperitoneal cavity. And because it causes lots of fluid accumulation in the abdomen starts getting all kinds of bulky, and you start looking like the Michelin Man. And what is this called when you start getting a lot of fluid accumulation within the abdomen? This is called ascites. And so another potential complication is that this can lead to ascites because of all of that massive fluid accumulation. The last thing that I want you guys to think about here, just quickly before we move on to the nasty complications besides these, is if it couldn't get any worse, you're probably like, oh, it can get worse? Yeah. One more thing is that if you have less effective arterial blood volume and less blood pressure, particularly less of the blood is actually going to the kidneys, what could that do to the kidneys? If there's less blood pressure because of less effective arterial blood volume, so less effective arterial blood volume leads to low blood pressure, you're not perfusing the kidneys. What can happen to the kidneys as a result? The kidneys won't get their volume of blood that they need to make urine. What will that do? That'll reduce their GFR. And that may lead to an acute kidney injury. What kind of acute kidney injury? Let's see if you guys remember from the AKI video. A prerenal AKI. So this would be a prerenal AKI because you have less blood volume. So they may have a bump in their BUN and a little bump in their creatinine because they're not having enough volume that's going to the kidneys because they're third spacing it, or they're just not having enough perfusion because they have less volume in general. All right, now that we covered that, let's cover some really, really scary, nasty complications of pancreatitis. All right, what's some other potential complications that you guys want to be definitely aware of in someone with pancreatitis? Well, remember, I told you that whenever there's all of this inflammation, right? So sometimes the pancreas can get super, super kind of inflamed. And when it starts getting really, really kind of inflamed, you know what is really interesting? There's a bunch of different types of enzymes that we talked about that can be released. So whenever the pancreas is damaged, not only is it because of this kind of like massive inflammatory cascade from like the cytokines, but also remember, whenever the pancreas is damaged, it was because of lots of maybe proteases that are being released and lots of lipases that were causing this massive destruction of that tissue, okay? Now, when the proteases and the lipases are causing this autodigestion of the pancreas, you know very, very interestingly what can happen? Let's say specifically with the lipases, what they start to do. The lipases, they start breaking down a lot of the fat, the peripancreatic fat. And when they start breaking down that peripancreatic fat, these lipases, they really start going ham and they start breaking down that peripancreatic fat tissue. You know what that leads to, this peripancreatic fat tissue, when it starts becoming destroyed and damaged? It leads to a process called liquefactive necrosis. So it's called liquefactive necrosis. And what's really interesting about this is you start damaging some of the actual pancreatic tissue. And as it starts damaging some of the pancreatic tissue, it starts releasing out some triglycerides as a response to this. Because you know, whenever you're breaking down lipids, you can actually start releasing some triglycerides as a response to this. Particularly, triglycerides will actually get broken down into these things called free fatty acids. So whenever we're breaking down the fat tissue within the pancreas, we're really breaking it down more specifically into these molecules called free fatty acids. So it's breaking down the fat of the pancreas, the lipases. These free fatty acids, you know what they do? They love to combine with something in the bloodstream. they love to combine with calcium. They really like to leach up all of that calcium. And so normally calcium should be circulating in our bloodstream in kind of a free form. But what happens is from all of this liquefactive necrosis process where you're destroying some of the peripancreatic fat tissue, releasing from that area lots of free fatty acids, they soak up the calcium. And when they soak up that calcium, it leads to a low calcium within the bloodstream. And this is called hypocalcemia. Now, this liquefactive necrosis, when it leads to all this damage and this hypocalcemia, we actually call it technically like a saponification reaction. But let's not get too crazy. We just know that there's definitely a lot of liquefactive necrosis. That liquefactive necrosis, right, you start getting a lot of inflammation and damage and fluid collections in that area. So you start getting lots of fluid collections, right, in that area. Here's what can really interestingly happen. All right, so what can happen is you start getting this area here where all of this inflammation, all of these fluid collections start forming. You start getting a lot of fibrous tissue that surround those fluid collections. So here we're going to have this fluid collection, and then surrounding that area of fluid collection is going to be this fibrous tissue, okay? So you have all of this necrosis, this liquefactive necrosis, and then what happens is, okay, so here's all that liquefactive necrosis. You start getting this area of a fluid collection that gets housed or walled off or encapsulated. What is this called? This encapsulated fluid collection. It kind of looks like a cyst. It's called a pseudocyst. This is called a pseudocyst, a pancreatic pseudocyst. You know what can happen though in certain situations? That pancreatic pseudocyst can sometimes very, very significantly, scary, can actually sometimes get filled with E. coli. So E. coli may actually infiltrate into this area of the pancreatic pseudocyst. And when it does that, if it gets in there and it actually causes like nasty bacterial infection to this area of the pseudocyst, now you have all this bacteria that's encapsulated. What is this called here? This encapsulated infection. This right here is called a pancreatic abscess. And so these are also potential complications. You know what a pancreatic pseudocyst, sometimes they can be completely asymptomatic. But if they get big enough, they can compress on things. Remember what I told you they could compress on the stomach near the gastric outlet, maybe lead to an obstruction. They can compress near maybe the bile duct. The bile duct runs through here. It could compress on that, leading to jaundice. It could compress on the duodenum, which runs right here, which can cause, again, an obstructive type of symptoms. So these are things that can happen. Abscesses, they're going to be very painful. They're going to have fevers. They're going to have severe abdominal pain. They're even going to have an intense leukocytosis. And this is going to be something that stays around. Usually, these complications usually develop over a process of greater than or equal to 4 weeks after the initial pancreatitis event. This is something that happens a little bit later. The last thing that can happen with respect to this liquefactive necrosis is that you get these fluid collections here that aren't encapsulated. Sometimes, okay, if these fluid collections become infected, then it's called a infected liquefactive necrosis. So you can get two types of liquefactive necrosis. You can have an infected liquefactive necrosis, or you can have it where it's just this fluid collection where there's no bacteria that infiltrated into it. And this is called a sterile liquefactive necrosis. Okay? So now we have an idea here of all the potential complications with the liquefactive processes, which is really kind of related to a lot of these lipases. Now, let's say that it gets even worse. Let's say it gets even scarier, really, where, again, this pancreas is getting inflamed, right, because of all of the pancreatic proteases, all the pancreatic lipases. And again, what starts happening here is you start, again, releasing all of these. There's all of these proteases that are being released that are causing autodigestion. There's lots of lipases that are getting released that's causing a lot of autodigestion. We already talked about the effect of the lipases. But what if these proteases and lipases start extending beyond the actual area of the pancreas? You know the pancreas has vascular supply as well. So proteases might start destroying some of the proteins. The lipids might start destroying some of the lipids that are associated with nearby blood vessels. If I start destroying some of these nearby blood vessels that are in the pancreas or near the pancreas, then I'm going to start having blood that's going to be accumulating around the pancreas. what is this called? This is destruction of nearby pancreatic tissue and pancreatic tissue in general, but now there's blood. This type of necrosis here is called a hemorrhagic necrosis. And the worst case scenario is maybe it's just like blood collections that accumulate near the pancreas from nearby pancreatic vessels. But what if this actually invades into a gastroduodenal artery, a gastroepiploic artery? Worst case scenario, it erodes into nearby aortic vessel. This could lead to hypovolemic shock because of a massive rupture. Okay, because of massive rupture of a large blood vessel. So that's another scary complication that can happen. So you can get this hemorrhagic necrosis, and this can lead to hypovolemic shock and bleeding. And this bleeding is what can really kind of be scary because it loves to bleed. You know where the pancreas is actually located? It's actually located within the retroperitoneum, right? So you have the peritoneum, which is having that, you have the visceral peritoneum, the parietal peritoneum, and it kind of helps to keep all of the organs located in that kind of like, imagine like a trash bag, right? You have all of that sitting inside of it. Well, behind that trash bag is the retroperitoneum. That's where the pancreas is located. And that blood can accumulate, okay? And it can accumulate in the retroperitoneum. And that can lead to very, very interesting types of signs that you may see in a patient. It's rare, and if you do see it, it's kind of an ominous finding. Sometimes you can see blood like this, like what looks like ecchymosis that kind of forms around the belly button. This kind of ecchymosis or hemorrhage, which is indicative of retroperitoneal bleeding, so you're kind of invading, what happens is all that proteases and lipases are invading and destroying nearby blood vessels, and it's causing retroperitoneal hemorrhage. This is called the Cullen's sign. Okay, I like to think about a C near the actual umbilicus. And then if you get a lot of hemorrhage that occurs near the flanks, you know, you got to turn on your side. This is called a Gray-Turner sign. And these are indicative of retroperitoneal hemorrhage from hemorrhagic necrosis. These are also some scary things that you want to be very, very careful of in a patient that has acute pancreatitis. Now that we've covered that, let's talk about the diagnosis. All right, so how do we diagnose pancreatitis? Okay, well, obviously they have to have that classic like signs and symptoms, right? So the epigastric abdominal pain, constant, radiating to the back. It's again worse, particularly when they're laying supine, feels better whenever they're laying forward. And again, they may have that associated nausea, vomiting. Those are the classic kind of signs of pancreatitis. So if you hear those things, then the next thing is to say, okay, we have that. Do they have any risk factors for pancreatitis? Oh, they had a history of gallstones. Oh, they're an alcoholic. Or they have particular hypertriglyceridemia. Again, go through all the causes. Think about those things. If they fit the bill, test the lipases. Remember, whenever there's destruction of the pancreas, all right, you start releasing out these lipases, and that lipase causes the liquefactive necrosis, the saponification reactions. And so whenever somebody has pancreatitis, they should have the lipases that are being destroyed and released into nearby vasculature. So what you do is you check their lipases. And if the lipases that you check with inside of the blood is 3 times the upper limit of normal, this is indicative of pancreatitis. There is another enzyme that you could check, but I think it's on the way out. Again, what is the other enzymes that were present? Not just the proteases. So there was proteases, lipases, and amylases. This one is not as good, but amylases, if they are also 3 times the upper limit of normal, and you find these higher up in the blood, again, that may be helpful in pancreatitis, but really the best one is just lipases because they're way more specific for the pancreas. Amylase can be released from multiple different areas. Remember, it's released by the salivary glands. So again, in some kind of situation where you tickle the salivary glands, if you're trying to intubate a patient who has pancreatitis, they may have an elevated amylase. So stick with the lipase and you can't go wrong. So clinical symptoms that we talked about, plus lipases that are 3 times the upper limit of normal, is diagnostic. You can also get imaging to aid in that diagnosis as well. What are some other things that you might want to throw on in order to make sure that you also kind of look at the pancreatitis, like grading its severity, looking for any complications, or figuring out the cause? The other thing that I like to look at here is I like to get a CBC. Now remember, in a patient who has pancreatitis, what happens to their vessels? They're super leaky, right? And so they're leaking out all of their plasma, lots and lots of their plasma. So if you were to get a CBC, all right, particularly to look at their hematocrit, I like to look at their hematocrit. And when I look at this, I'm going to see, let's say here, about 45% of that hematocrit should be red blood cells. Then you should have a tiny bit of it, like less than 1%, that's a part of your buffy coat. And then the last part should be your plasma. But what's happening to these patients with pancreatitis in severe cases? They're third spacing a lot of that fluid. And so their actual plasma may be very low. Normally this is supposed to be 55. But if you take and try to calculate the hematocrit, what is it? The hematocrit is basically taking the red blood cell layer over the total blood, which includes the buffy coat and the plasma layer. Well, if the plasma layer is really low, what's going to happen to your total hematocrit? The hematocrit may be higher. So this could be indicative of something called hemoconcentration. Now, what's another thing though to think about that maybe it's not just this? What if the pancreatic inflammation actually caused the necrosis or destruction of nearby vessels and you started actually leaking tons of blood into the retroperitoneum? What may be another sign that you would see in these patients? Not just a high hematocrit from hemoconcentration, but you may see a low hemoglobin if there was any kind of retroperitoneal hemorrhage or bleeding. So this may be indicative of bleeding. So that's something I would think about. Is there any hemoconcentration? Maybe they're third spacing a lot of the fluid. Is their hemoglobin low? Maybe they're bleeding from a retroperitoneal hemorrhage. I can get a lot of that from a CBC. What else could a CBC tell me? What happens to our white blood cells again? You make more of them. So another thing that we may pick up from the CBC, besides a drop in hemoglobin indicative of bleeding, a high hematocrit indicative of hemoconcentration, but I may have more of these neutrophils. And what is this here called? My white cell count would be going up, and this is a leukocytosis. Maybe more specifically, I'd see a lot more neutrophils within my white blood cell, my CBC, particularly within the white blood cell component. Okay, so right now I can tell from my CBC if there's any hemoconcentration, bleeding, or a leukocytosis. Pretty good stuff right there, right? What else could I do? The other thing I could do is I could just check a lipid panel, right? Why? Why would I check a lipid panel? Particularly, the more specific one. Let's actually be more specific. I can check a lipid panel, but really I'm only looking for one component in that lipid panel, the triglycerides. So I could quickly order someone's triglyceride level. Now this is actually high yield. I do want you guys to know this. I don't want you to remember numbers too often, but this is one that you need to remember. The triglyceride levels, it actually has to be greater than or equal to 1,000 milligrams per DL to actually be significant enough to cause pancreatitis. So you have a pretty good hypertriglyceridemia. You see this, greater than that, it's probably cause of their pancreatitis. So that's another thing I'll do. I'll check their triglyceride level. So I'll send off for a CBC, I'll check their amylase and lipase, I'll check their triglyceride levels, and then another thing I'll do is, what's another potential cause? It's an easy one. I can quickly order it. I can order a calcium level, right? So I can check their calcium. And the calcium could be two things, right? If the hypercalcemia is there, that might have been their cause of the pancreatitis. But what did I tell you may happen as a result of the liquefactive necrosis? Remember the free fatty acids get released, they combine and complex with the calcium? What also could be a complication? You may also have hypocalcemia, but this is a complication. This may be a result of that saponification or liquefactive necrosis. So if it's super high, ooh, that might be their cause. If it's low, ooh, that could be a result of that liquefactive necrosis process. All right, what else would I check? Obviously, I would check all their vitals. Do they have hypotension? Do they have tachycardia? All of those things. But what was another thing I said? If they have a lot of this third spacing of fluid and they have a low blood volume, particularly what? We got to be specific. A low effective arterial blood volume. That's less perfusion to the kidneys. Less perfusion to the kidneys means less urine output. But what did I say would happen? If you're not perfusing the kidneys, they have a low GFR. They're not excreting urea. And what happens to their BUN? It goes up. So what could I do to check the person's BUN? A BMP. So I could check a BMP, and that may give me their BUN. It also may give me their creatinine. They may also have a small bump in their creatinine as well, but this is the more important one, the BUN, okay? All right, so that's one thing. What's another thing I do? Remember I told you, this also is a very interesting thing. Where is my maroon marker? Here it is. Okay. With all of this things that we were talking about, right? Especially with the inflammation. So remember those macrophages? They were releasing tons of interleukin 1. They were releasing tons of interleukin 6, and that was acting on the liver. And it was telling the liver to make a lot of acute phase reactive proteins. What were the particular ones that I wanted you to remember? CRP. So another thing I could check if I really wanted to is I could check a patient's CRP, and if their CRP is really high, and I have a lot of these other things, ooh, it could be a pancreatitis. But remember, it's not super specific. Remember I told you could check another thing, which is a little bit better, but it's only really particularly seeing if the patient has pancreatitis with infection, like an infected necrosis. That's called procalcitonin. So another thing that you could add is what's called a procalcitonin if there is question of infection. So sometimes people have pancreatitis, it can look like they have an infection, right? They have a fever, they have hypotension, they have tachycardia, they have a leukocytosis, and you're like, dang, I don't know. Maybe they have an infection. Sometimes procalcitonin may help to guide you to say, is the pancreatitis, all that necrosis that they have, becoming infected? Do they have an abscess? That may be helpful in these scenarios. The next thing that I want you guys to remember is, what if a patient's cause was a gallstone, right? They have a gallstone that's stuck at that hepatopancreatic ampulla, right? We know that that could cause the pancreatitis, but we know that some of that other stuff can back up into the liver. It can back up into the gallbladder, all right? And what is some of the things that can actually back up? Well, we know that they can have an increase in bilirubin. And if there's enough that enough of the bile starts backing up, and it actually causes liver injury from all of the pressure, from all of this kind of blockage here, that could lead to an increase in what other things? Liver enzymes. What are the liver enzymes that could be indicative of liver injury? AST and ALT. So another thing that I could do to see, is this maybe related to the gallstones, is I could check a bilirubin, and I could also check their AST and ALT to see if the liver has any kind of relationship involvement here. Okay, so we kind of got a good idea of what I can check here to see what's going on with this patient. So now that we've gone through the clinical features, the labs, what are some particular images that we could add on to aid in our diagnosis or figure out the cause? All right, so what kind of imaging would we order for this patient who we think has pancreatitis? Well, let's say that they have the classic features, their labs, particularly what was the most important one? If you forget all that stuff up there, that's fine, but only one lab I need you guys to remember. It's the lipases. Has to be 3 times the upper limit of normal, epigastric abdominal pain in the classic kind of presentation. What else is another thing that helps us to diagnose it? The other thing is particular imaging. So one of the first things you should do is obviously order a lipase, order some of the other stuff that we talked about, but I would get a right upper quadrant ultrasound. The reason why is a right upper quadrant ultrasound may tell you the exact cause of the person's pancreatitis. If I get the right upper quadrant ultrasound and I see any type of stone, so I see the evidence of the actual gallstone, or I see any ductal dilation, that might right away tell me, oh, there's their particular cause of pancreatitis. It's not super great if they have a lot of particularly like enlargement of their abdomen, like a distension, lots of bowel gas. It may obstruct the pancreas. If you're really good at ultrasound, sometimes you can pick up particularly like fluid collections like pseudocyst and walled off necrosis. But I think the right upper quadrant ultrasound is kind of like the quick thing that you should do to see, is there a stone? Is there any ductal dilation? Let's take a look at an ultrasound and see what that could look like. All right, Ninja, so we talked about the ultrasound. Let's take a look at what we would really kind of be looking for. If we did a right upper quadrant ultrasound, we see here we have this big kind of structure here, the gallbladder. And the gallbladder should eventually kind of connect, particularly has the cystic duct that fuses with the common hepatic duct, and then you get the common bile duct. What happens is when your common bile duct is approaching anywhere near like 10 millimeters or greater, that's some pretty significant dilation of the common bile duct. And what we might want to suspect is that there's something downstream that's plugging up that biliary duct.
And that, in my friends, is actually a gallstone. And so this patient had gallstone pancreatitis, and when we did a right upper quadrant ultrasound, they had a very dilated common bile duct due to a downstream gallstone. So again, that's one of the quick ways that you can see, is there a gallstone? Is there any ductal dilation that may be suggestive of gallstone pancreatitis?
All right, what's another potential test that I could do? All right, so let's say that I know a patient has pancreatitis, and I think that their cause of pancreatitis has something to do with a stone. Maybe their ultrasound was kind of inconclusive. So maybe it was inconclusive. I still don't know if there was any ductal dilation, if there was any stone. I saw some non-specific stuff, maybe related to pancreatitis, potentially. What I may do is I may do something called an MRCP. It's basically an MRI, and it looks at particularly that entire kind of pancreatic and biliary system to look to see, is there any kind of filling defect or any point where there's a stone or something blocking some part of that hepatopancreatic ampulla, biliary system, pancreatic system. So that's a good thing. The other thing that you may do is, if you have a very high suspicion and the patient is kind of like not super stable, you may go straight to a ERCP, because this is both diagnostic and therapeutic. So with this one, you actually take and run the camera down, or you actually run the catheter down through the duodenum, up through the pancreatic duct, up into the actual biliary system, and then you kind of shoot some contrast up there to see, is there any kind of gallstone or issue there? And then from there, if you find it in real time, you can actually extract and remove that stone in the process. So that's another thing that you could do. So we'll take a look at an MRCP here in a second, then we'll take a look at a video of an ERCP.
So let's take a look here at an MRCP that maybe we're going to take the extra step here. As we move through an MRCP, which is just a magnetic resonance cholangiopancreatography, what I really want you to focus on is this area here. This right here is going to be the area of the gallbladder. Okay, so we're kind of filling up the biliary tract with any kind of like contrast. And we're getting down to the area of like where the cystic duct and the common hepatic duct should fuse and form what's called the common bile duct. So I want you to kind of follow this down. Anytime you see kind of any dark areas, it may be identifiable of something that's causing a defect or something that's blocking contrast moving down there. So let's move through there, and you kind of already see something dark right here. So there's some signs here of some gallstones that are kind of clogging up this common bile duct right there. You see definitely some stones, something that's kind of clogging that up. And then right around here is our pancreas. The main pancreatic duct should fuse with that common bile duct. So if we continue to follow it down, it would eventually kind of fuse around this area of the head of the pancreas with the common bile duct will fuse with the main pancreatic duct into the area of the hepatopancreatic ampulla. Okay, so this right here could definitely be an evidence of some type of gallstone pancreatitis, or maybe like some mild ductal dilation here that you can see on the MRCP. Okay, let's take a look now at an ERCP, but before we do that, let's take a look at kind of the overall concept that I want you guys to get from this. Boom, we got a big old gallstone smack dab within that bile duct and a little bit of ductal dilation. All right, let's take a look at an ERCP now. All right, so let's take a look here at an ERCP. So again, we can kind of see that we're coming down endoscopically and we're kind of running through the hepatopancreatic ampulla in near the area of the main pancreatic duct and then up through the common bile duct. And as you can see here, we have a suspicion that this person has some type of gallstone-related pancreatitis. And as you can see, you can kind of see that this common bile duct is a little dilated, and there may be some stones, a couple stones kind of lodged within this area of the biliary duct, and maybe even downstream near the where the hepatopancreatic ampulla is. And so again, this may be something that's interesting with the ERCP, where you may be able to diagnose the person having gallstone pancreatitis or some type of choledocholithiasis, or maybe complications like ascending cholangitis, and then therapeutically you might be able to treat and remove those stones at the same time in real time. So this is kind of an interesting ERCP that we are going to be talking about here.
All right, what's another potential thing that I could look for? Okay, the other thing that you could do is you could get a CT scan. Now a CT scan is relatively good. Okay, so CT of the abdomen. Again, I would try to hold off. So like the first test I would advocate to do is a right upper quadrant ultrasound. It's a super quick, easy test. MRCP, ERCP, if the ultrasound is somewhat inconclusive. If you're concerned about complications of pancreatitis, what do I mean? So it's been a couple weeks and they're still having some kind of weird symptoms of pancreatitis or some non-specific symptoms. You may be able to pick up that pancreatic pseudocyst. Remember, that's that fluid collection that's kind of encapsulated. The other thing it may help to pick up is there a fluid collection that looks like it's kind of loculated and has infectious material in it? In other words, is there any abscess? And it also helps to pick up on if there's any kind of necrosis. So necrosis particularly, is it infected necrosis? Is there any hemorrhagic necrosis? Is there any bleeding as well? Which again can be a complication as well. So these are good things for the CT. So a CT of the abdomen really shouldn't be like a first-line test. It's very good, but a CT of the abdomen, it may show a lot of peripancreatic fat stranding, which could be obvious, but usually in the acute phase, it may be hard to see because of so much inflammation going on that it may be difficult to demarcate a lot of the margins of the pancreas. But one of the things that this is best for is it's best for an unclear diagnosis of pancreatitis, or you have fears that there's some type of complication of the pancreatitis, as we mentioned here on the side, such as, do they have a pancreatic pseudocyst? Do they have an abscess? Do they have an infected necrosis, like an area of kind of infection necrosis? Is there any signs of bleeding due to the hemorrhagic necrosis? Those are things that you would definitely want to get a CT for.
All right, engineers, let's take a look here at a CT of a patient with pancreatitis. So we're looking at a CT. This is a axial section here. This is the right side of the body. This is the left side of the body, just so you remember. We got the heart here smack dab in the middle. As we start working our way down, we're going to get into the abdomen. So now we're in the abdomen. You can obviously see the liver here. You can see a lot of fluid behind here, so obvious evidence of ascites. But as we continue to go down, we see the stomach. And we're looking for the pancreas to be right behind the stomach, right in this vicinity, about right here. So let's see if we start to see it pop up. And there is our pancreas right here. Best way to kind of identify the pancreas is you see this vessel here. This is one of the splenic vessels. It usually kind of curls around that posterior edge of the pancreas. So here we have the pancreas, and what you're noticing is just a lot of like this like white stranding type of like matter all around it. All of that is kind of edema, but it's indicative of what's called peripancreatic fat stranding, which is pretty indicative of pancreatitis. So we definitely see a lot of inflammation around the area of the pancreas, thus indicating, again, pancreatitis, especially in the clinical context of this patient who presented with abdominal pain. They presented with fatigue, nausea, vomiting. So these are constant things, as well as a elevated lipase level that was 3 times the upper limit of normal. Okay, that's our image here. So if we take a look at what's the overall thing, we see here is our pancreas right behind that splenic vessel. You can see that kind of structure there. And all of this fat stranding around there is the peripancreatic fat stranding from the liquefactive necrosis, which is indicative of pancreatitis. All right, let's take a look at another thing that we can see in the CT. All right, so remember I told you guys that when we're get a CT of a patient with pancreatitis, it's important to remember that we're doing it to look for any complications of someone who may have pancreatitis. So we try to do it a little bit later within the stages of pancreatitis. And one of the reasons why is, one of the things that you might start seeing signs of is, again, we have to find the pancreas. So the pancreas, I kind of look for that splenic vessel, right? Splenic vessel, here's your spleen. So there should be the pancreatitis here. The pancreas is so inflamed that it is almost so difficult to be able to make out and demarcate all of the margins of the pancreas in this guy, right? It's around this vicinity right here, but you're seeing all of these like fluid collections and necrosis all around the vicinity of the pancreas. All of this is kind of this necrotic tissue around the area of the pancreas with lots of fluid collections. So those fluid collections are becoming infected or necrotic. And so that could be indicative of particularly a necrotizing pancreatitis in this patient. Okay, so let's take a look here at what we kind of highlighted. Again, we have some necrotizing tissue here. Again, this could have been from a lot of the necrosis of the tissue, liquefactive necrosis as well. All right, so that is necrotizing pancreatitis. Let's look at another complication that we can see from pancreatitis. All right, so let's take a look at another CT of a patient who we suspect has pancreatitis, or we're trying to exclude some other complications, or particularly we think that maybe there's something else going on. And as we start scrolling through this patient's, oh my gosh, look at this big beast in here in their abdomen. This is a massive pancreatic pseudocyst. It's so big that it's actually compressing the nearby ureter and causing a hydronephrosis of this kidney here. So this is a big beastie boy here, and it's a pretty significant complication that you can see like 4 weeks after a person who had pancreatitis, acute pancreatitis. And this is definitely one of the reasons why we would get a CT for a patient. Okay, so again, that would be an identifier of what again? this would be a pancreatic pseudocyst that we would see in a patient usually a little bit later after the initial stages of pancreatitis. And this is definitely important.
The other test that you can order is you can get an abdominal x-ray. An abdominal x-ray is also a really quick, easy test because it can help to rule out any kind of signs of bowel obstruction as well. But an abdominal x-ray, what you're looking for is whenever there's lots of inflammation of the pancreas, one of the things that it can do is it can really cause some dilation of the nearby small bowel. And it can kind of really make it look a little dilated. And this dilation of the small bowel is called a sentinel loop. Okay, and we'll take a look at not only just a abdominal x-ray, but also take a look at some CT scans to look at some of these abnormalities and complications. But that's one thing, is you may see some dilation of the nearby small bowel. You know what else is interesting? If there's lots of inflammation near the tail of the pancreas. You know the tail of the pancreas is near this area called the splenic flexure. The splenic flexure can get lots of inflammation and fluid collections that can compress down on that splenic flexure. And if you can compress down on it, that causes an increase in the back pressure proximal to that. And that causes some dilation of the bowels that are proximal to the splenic flexure. What's proximal to the splenic flexure? Well, then you have your ascending colon and you have your transverse colon. They can actually be super dilated and kind of like large. So sometimes if you also see this dilation of the ascending colon, transverse colon, and then a cutoff near the splenic flexure, that may also be a sign of pancreatitis. And this is called the colon cutoff sign. So something on abdominal x-ray that they may ask you as kind of like those buzzword terms, not super common to think about, but definitely something to remember is there a sentinel loop, nearby dilatation of the duodenum, or nearby compression of the splenic flexure that causes bowel gas appearance of the transverse colon and ascending colon. Let's take a look at some of these images and then let's talk about the treatment of pancreatitis.
All right, so let's take a look at an abdominal x-ray. Again, these aren't like super diagnostic of a patient who we suspect has pancreatitis. It's just something that if you see it, hey, maybe they could have pancreatitis if their symptoms and some of their labs are kind of indicative of that. But again, something that you may see on your exam as a very important thing is what's called a sentinel loop. So what happens is because of all that pancreatic inflammation, you get kind of a localized ileus, and you kind of see this bowel gas pattern that almost looks like an obstruction, but it's a non-obstructive type of bowel gas pattern. And this is called a sentinel loop. So this may be something that you can see, whether it be nearby the pancreas, maybe it's a little bit more downstream. Seeing these kind of dilated bowel gas patterns without an obvious form of obstruction is indicative of potentially an acute pancreatitis. All right, let's take a look at another one called a colon cutoff sign. All right, so let's take a look here at the last image that I want you guys to be thinking about, particularly with acute pancreatitis, especially on your exams. But again, if a patient has some symptoms of acute pancreatitis, potentially concerning on some of their labs, like the lipase, and you get an abdominal x-ray because they're having abdominal pain. And this part here, you kind of see what's interesting. You kind of see this bowel gas pattern. So it kind of looks like there's some bowel gas pattern here, particularly within like the area right around the splenic flexure, transverse colon, and then you can't see it, but it would go down into like the ascending colon. So this is interesting. There's definitely some bowel gas patterns and what looks like a cutoff just around the area where the splenic flexure ends, and we go down into the descending colon. What happens is whenever there's pancreatitis near the tail end of the pancreas, that inflammation can cause, again, somewhat of a nearby kind of obstruction kind of pattern here. It's not a complete obstruction, but there's enough inflammation here that it causes this cutoff sign near the area of the splenic flexure and then causes this dilated bowel gas pattern proximal to that. This is indicative potentially of an acute pancreatitis, and we call this a colon cutoff sign. All right, that covers our images that we're talking about within the diagnostic section. Let's now move into the treatment section.
What I want you guys to understand is kind of like the hallmark, the backbone behind treating pancreatitis. And the first one is your fluid administration. So we're giving fluid to these patients. Why? Well, because they're having a vasodilatory effect, right? And what that vasodilation is doing is there's a drop in blood pressure, right? So there's hypotension. The second thing is it's causing a lot of edema or third spacing of fluid, right? So we call that third spaces when it's kind of the fluid is accumulating in interstitial spaces, whether that be within the the lungs, pulmonary edema, and the lower extremities, peripheral edema, whether that be in the abdomen causing ascites and things of that nature. That's some of the complications or fears. And so what we want to do is we want to give fluids. And there's two types of fluids. You can give normal saline, you can give lactated ringers. I'm more of the lactated ringers one because some of the literature actually shows that it may be superior to normal saline in these patients. But one of the things that you have to be giving fluid for, because one of the things that they say is you got to push in like 10 to 12 liters of fluid to these patients within the first couple hours. No, my gosh, please don't be pushing this much fluid into your patients. The reason why is if you're giving too much IV fluids, excessively large volumes of fluid, they're just going to keep third spacing that fluid. That's the problem with these patients. And you increase the risk of fluid overload. Particularly, what's one of the complications associated with patients particularly developing very severe pancreatitis, ARDS, right, from the increased capillary permeability. If they have increased capillary permeability and you just flush them with tons of fluid, you're just going to push all that fluid into their interstitial spaces, into the lungs, worsen their potential ARDS, or put them into ARDS. The other thing is if you give them tons and tons of fluid and they just keep third spacing it into the retroperitoneal cavity and all their abdomen, then they're going to cause the pressure in their abdomen to rise so much that you're going to lead to what's called abdominal compartment syndrome. Abdominal compartment syndrome. And these are just negative things, man. So what I try to say is give them fluids, particularly lactated ringers, and target have targets. Target their blood pressure, like maybe their MAP is one target. Maybe you target their urine output as another target. Maybe you're looking at their BUN and looking to see if that's improving. Maybe you're looking at their hematocrit to see if that's improving, right? So if you're giving them fluid, hopefully their MAP goes up, hopefully their urine output increases, hopefully their BUN goes down, hopefully their hematocrit goes down because they're having less hemoconcentration. These are kind of parameters to be looking at when you're giving fluid. Don't just blindly give someone 10 to 12 liters of fluid in the first 24 hours and then not pay attention to them. They might put them into ARDS or abdominal compartment syndrome, okay? So first thing is fluid administration. The next thing is this disease is very painful. So analgesia is a very important thing. And so one of the things that we try to go with is obviously when you're giving analgesia, you can start off with something like Tylenol. That might not be enough. And that's when you go to the next step. So maybe the Tylenol isn't working. The next thing you go to is PRN opioids. Okay, so you may try things like fentanyl and see if that works. You may try things like, particularly like hydromorphone and see if that works. And usually if these don't work, maybe you have to go to the next step, which is things of, particularly like, they say that morphine may cause spasm of the sphincter of Oddi. That's kind of not like some of the literature is actually kind of going against that. They say like meperidine may be a good option for that. But again, I think that's kind of like they're changing a little bit of that in the literature. But yeah, there is the questionable concern of whether morphine can cause spasm of the sphincter of Oddi. I don't think that that's super true based upon kind of like the literature. But PRN opioids may be an option. And another thing that you may want to consider that I'm a big fan of, especially in these patients, is maybe a low dose ketamine infusion. The reason why is, here's the thing, whenever you're giving patients who have this pain opioids, what can opioids do to the actual bowels? It can decrease the contractility of the bowels. And so if you're giving all of these tons of opioids, what can that do? That can actually lead to an ileus. And if you lead to an ileus, you're just going to worsen their condition that they already have with pancreatitis. So I'd be very careful. Yes, you have to treat their pain, but try things like Tylenol, try things like low-dose ketamine, and then if you have to, go to your PRN opioids. And sometimes you may have to get it pretty scheduled. Okay? All right, what's the next important thing? This is actually a super important one. So whenever patients who develop pancreatitis, what we found is that, yay, let's make them MPO. Let's give them some bowel rest. Maybe we have to put in an NG tube if they're having lots of inflammation, they're vomiting all the time. If that's the case, yeah, I think it's a good idea. If they're having lots of pain, they're having lots of nausea, they're vomiting a lot, they have a lot of inflammation and gastric outlet obstruction, sure, make them MPO, put an NG tube in to decompress the bowels. I think that's a good idea. But once they're pain-free, the literature actually is showing that you should try to feed them early. So maybe you feed them early via oral if they can tolerate it, or maybe you do this via some type of NG tube. Regardless, enteral feeding early has been shown to be able to actually change the gastric permeability, because whenever there's lots of inflammation with the pancreas, it can cause the gut to become super permeable. And imagine if the gut is super permeable, what can actually pass across the gut? That's a part of our natural flora, bacteria. And so bacteria can actually translocate when there's all of this permeability. They found that whenever you do oral feeding early or NG tube feeding early, this was shown particularly to inhibit this process, to inhibit the gut permeability, inhibit bacterial translocation, and reduce the risk of infection associated with pancreatitis. So that's another important thing. Fluid, don't crush them with fluids though. Pain control, try to avoid tons of opioids. Third thing, nutrition. If they need some bowel rest because they're vomiting, they're in lots of pain, make them NPO, put an NG tube to decompress the bowel if need be. Once they're pain-free, get them eating. If they can orally tolerate it, good. If they need an NG tube and you have to feed them that way, good. Just do it early so you reduce the risk of infections. What's the next thing? Okay, so we've done kind of our conservative measures. Now we're kind of getting into the particular cause-related things for pancreatitis as well as complications. So the next thing that I want you guys to be thinking about here is, what if somebody's cause, oh my gosh, so loud, they have a stone. They have a stone there stuck within the hepatopancreatic ampulla. And we know that the cause of that stone is because they have some type of gallbladder disease. You know, they have what's called cholelithiasis, and they're constantly popping out these stones that are getting stuck down in the actual hepatopancreatic ampulla. What can I do to remove that stone and then reduce the risk of reoccurrence of them developing gallstone pancreatitis? I can go in utilizing this type of tool here coming down the duodenum, cutting open the sphincter of Oddi, and then sucking out that actual stone. What is that called? It's called an ERCP. So that would be one way. One way is we're removing the stone via an ERCP. Or what's another thing that we can do besides this, plus or minus, if they have a high risk of recurrence and we want to reduce that risk of recurrence, what could I do? I could just cut this bad boy out, reduce the risk of forming any types of gallstones, reducing them actually being dislodged into the ductal system and causing an obstruction of the pancreatic ampulla there. And so this would lead to a cholecystectomy, which we'll abbreviate as CCY, okay? So this is another potential thing that you have to be thinking about. If the patient has gallstone pancreatitis, ERCP plus or minus cholecystectomy to reduce the risk of recurrence. Okay. The next one, I really want to mention this one because it's actually super cool. I've seen it once. I've seen a patient who was on tons and tons and tons of propofol, and they developed a super crazy high hypertriglyceridemia. It was in like almost near the 2000s. And that hypertriglyceridemia had actually induced pancreatitis. And so what happens is, you know what's actually really interesting with this is obviously you want to discontinue the offending agent, whatever the cause is. In this case, if it's propofol, or if they have some type of like genetic condition. Sometimes an alternative, like a mutation or deficiency in an enzyme called the lipoprotein lipase enzyme, that can actually cause this. So there is genetic conditions that can increase your risk of hypertriglyceridemia. But whatever the cause of it is, you have to reverse that. But then we got to treat it. So there's insulin. You know, you give a patient insulin. You put them on an insulin infusion, and we'll put it as a drip, GTT, right? So you put them on an insulin infusion. What the insulin infusion does is it actually stimulates a very special enzyme called lipoprotein lipase. And what lipoprotein lipase does is it actually helps to break down these triglycerides. So if you have tons and tons of triglycerides within the blood, it breaks down the triglycerides into free fatty acids and into glycerol, effectively lowering the triglyceride concentration, because this will get taken up by muscle cells and cardiac cells and different tissues. So that's one particular thing that we may do. Now, if that doesn't work, you know what else we can do? You can actually give them another drug that actually helps to inhibit triglyceride formation. Another drug that you can give besides insulin drip is you can give something called fibrates, Fibrates have been shown to be able to kind of reduce triglyceride production. And the third thing that you may do is if they're refractory to all of these things, is you may actually have to you actually take their blood out and then through kind of a machine that sifts all of the actual fat out and then sends their blood back in. And that's called an apheresis. So these are interesting things that you might have to do as well. So lipoprotein lipase can be stimulated by insulin, fibrates, and then plus or minus apheresis if they're very severe hypertriglyceridemia. Okay, now we're on to the next thing. So fluid collections. So we know that with all of that necrosis and inflammation, you can start developing lots and lots of fluid collections around the pancreas. And now here's the thing though, these fluid collections that you can get, they can be completely sterile. So you can get all of these fluid collections and they can be a completely sterile type of fluid collection. You don't do anything about these, you just observe. There's no particular type of treatment for these fluid collections. Now the question is what happens if these sterile fluid collections that you get because of all of the type of liquefactive necrosis, all of the inflammation, all of the hemorrhagic necrosis occurs, what do I do if you start actually getting some fibrous tissue? So you start getting like fibroblasts, they start coming to the area, and these fibroblasts, in response to all of this inflammation, they start making lots of fibrous tissue. And that fibrous tissue starts walling off these fluid collections. What is this called? This is called a pancreatic pseudocyst. Now, pancreatic pseudocyst, guess what you do? Well, remember, when do these actually form? There's the complications that come down the line, usually greater than or equal to 4 weeks. After the initial event of pancreatitis, you can develop these. You know what you do with these? If you're asymptomatic, you just observe. And you just hold on, and usually these will resolve and they won't cause any problems. Now, if they develop symptoms, what the heck does that mean? If they develop symptoms, well, think about it. What if that actual, so let's say that here, for example, let's say here we put the pancreas, and let's say here we have a big pseudocyst. Right, here's a big pseudocyst. What are the things that it could compress nearby? What would be right above the pancreas? What's right here? Stomach. What's coming around the pancreas? Duodenum. What's a structure that runs down from the gallbladder and fuses with the pancreatic duct, the bile duct? If the pancreatic pseudocyst is getting so large that it's causing persistent pain and it's compressing the gallbladder causing jaundice, the bile duct causing jaundice, it's compressing the gastric outlet causing vomiting, nausea, as well as bowel obstruction. It's compressing the duodenum causing bowel obstructive symptoms and malabsorption. Then you would go in and drain the actual abscess. You may do what's called a percutaneous drainage. Okay? So you stick a thing in there, a little needle in there, and suck that little out. Suck all that fluid out, okay? That may be something that you go to. You try to be able to avoid this at all possible, but if the symptoms become very persistent and problematic, then you may have to percutaneously drain that pseudocyst. Okay, the next question. Okay, what if that pancreatic pseudocyst was not problematic, right? So here's my pancreatic pseudocyst, and it's got some sterile fluid in there, but all of a sudden, some E. coli, some nasty little bugger E. coli start saying, I like me a pseudocyst, and it starts infiltrating into that pancreatic pseudocyst. And now that pancreatic pseudocyst starts getting tons and tons of bacteria that is now walled off by this fibrous tissue that was persistently there with the pancreatic pseudocyst. Now what do I have? Now I have a pancreatic abscess. A pancreatic abscess is going to cause persistent abdominal pain, persistent fevers, leukocytosis, a palpable mass, and they can really look septic appearing. In these patients, you get that CT, you find the abscess, what do? Well, you may start off with antibiotics. What antibiotics is actually preferred in a patient with pancreatitis, but is an abscess related? They have an infected necrosis. Remember, pancreatitis in general, you do not start antibiotics. You only start the antibiotics if they have evidence of an abscess or some type of walled off infective necrosis, not in general. The antibiotics that you start with are your carbapenems. 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 So meropenem, imipenem, these are the general ones that you're going to start with. So carbapenems would be kind of your first go-to. Now, if you start the carbapenems and they're still maybe not getting any better, you may actually have to suck some of that pus material out. And so you may also have to do particularly a drainage. You may have to do what's called a CT-guided drainage of that area, okay? Now the question is how the heck do I figure out if this is actually infection versus just a pancreatic pseudocyst? The only way that you may figure that out is you may kind of go based upon their clinical features, but you may have to do what's called a fine needle aspiration. So you may have to take and suck out some of that material from what you think is either an abscess or a pancreatic pseudocyst, take it out, send it out for culture, all the gram staining process, and if it comes back positive, then you treat them with antibiotics, and then you suck all the actual pus out of there, okay? Now here's the next question. Okay, so we have a patient with that sterile necrosis, right? So let's go back to that. You have a patient with these fluid collections here, right? So these fluid collections and it's sterile. Okay, so here there's their sterile fluid collections that they have. It's not infected, so it's sterile. Do you give these patients antibiotics? No, no antibiotics, you just observe. If over time, these fluid collections that you have start getting walled off, so maybe you start getting some fibrous tissue around that area that start walling off these fluid collections. And then on top of that, not only do you have the necrosis with the fluid collections and the fibrosis, but now bacteria start invading into that necrotic area. The bacteria start invading into that necrotic area. What is this called? This is called infection necrosis. So this is called a infected necrosis. In this situation, you may start antibiotics. What type? Carbapenems like meropenem or imipenem. How do I determine, though, that this is a sterile necrosis versus an infected necrosis? What may I have to do? A fine needle aspiration, right? So I may have to suck some of this actual material out via a fine needle aspiration, send it off for a gram stain, send it off for cultures, and if it comes back positive, oh, it's infection, treat it with antibiotics like imipenem or meropenem. And then, you know what I may have to do? I may have to cut that necrotic tissue out. So in this one, I just drained it in the abscess. But in this one, I may actually have to cut the necrotic tissue out. And so sometimes we may have to do what's called you may be able to do it percutaneously, but generally you have to do what's called a debridement. So you may have to debride this area. Now you can do this endoscopically, where you actually go in kind of percutaneous, like you may do it endoscopically, percutaneously, or you may open them up and then cut out some of that necrotic tissue. But generally, we have to debride this area. And so we may do again, an endoscopic type of procedure debridement, maybe a percutaneous or an open necrosectomy. So these are things that we may have to go to if there's an infection necrosis as well. And Ninja Nerds, this covers pancreatitis. I hope this made sense. I hope that you guys enjoyed it. And as always, until next time.